Have you ever stopped to wonder whether the very medications meant to protect your health could quietly be reshaping your brain in ways you never intended? After the age of 40, life often becomes a careful balancing act. Blood pressure creeps upward, sleep becomes lighter. Old injuries begin to speak louder. Responsibilities expand, while recovery time shrinks. In response, prescriptions accumulate. One medication for hypertension, another for chronic pain. Something to help you sleep. Perhaps an antidepressant to steady mood. Each prescription seems reasonable in isolation, rational, clinically justified, even necessary. Yet when these compounds converge inside the intricate circuitry of the human brain, something more complex begins to unfold. This phenomenon, known as polypharmacy, is not inherently dangerous, but it carries a hidden vulnerability that too few people truly understand. The brain does not compartmentalize medications the way medical charts do. It does not recognize separate providers or separate diagnoses. Instead, it integrates every chemical signal into a unified neurobiological response. Dopamine pathways governing motivation and reward. GABA circuits responsible for calming neural excitation. Serotonin systems stabilizing mood and impulse control. Opioid receptors mediating pain and pleasure. When multiple medications simultaneously influence these systems, the cumulative effect can alter the delicate balance that sustains resilience. Tolerance may develop gradually. What once relieved discomfort may require a higher dose. Sedation may deepen subtly. Emotional reactivity may shift. Over time, cross-dependence can form, meaning the brain adapts not to a single agent, but to a constellation of chemical inputs working together. Midlife represents a unique inflection point. The body's metabolic processes slow. Liver and kidney clearance may decline. Hormonal fluctuations alter stress responsiveness. Responsibilities intensify, while recovery mechanisms become less forgiving. In this stage, polypharmacy becomes more common, not because individuals are careless, but because complexity increases. Chronic pain conditions, metabolic disorders, anxiety syndromes, insomnia, and mood disturbances frequently coexist. Each condition is treated according to established guidelines, yet guidelines rarely account for the cumulative neurochemical load. This is where insight becomes essential. Clinical researchers and addiction specialists, including Dr. Anna Lemke, have emphasized how modern medicine's well-intentioned interventions can inadvertently amplify reward pathway sensitivity. The brain, exposed to repeated pharmacological stimulation, may recalibrate its baseline. Dopamine signaling becomes less responsive to natural rewards such as exercise, connection, creativity, or achievement. The individual may not feel addicted in the conventional sense, yet motivation subtly shifts toward the substances that most reliably regulate discomfort. The change is often gradual, almost imperceptible. There is no dramatic turning point, no obvious moment of loss of control. Instead, there is adaptation. This adaptation is neither moral failure nor weakness. It is neurobiology. The nervous system seeks equilibrium. When medications dampen stress signals or elevate reward signaling, the brain compensates. It reduces endogenous production. It alters receptor density. It recalibrates thresholds for stimulation. Over months or years, what began as therapeutic support can evolve into physiological dependence. The person remains functional, productive, outwardly stable, yet internally reliant on chemical scaffolding that has become more difficult to adjust or remove. Understanding this dynamic is not about fear. It is about awareness. Polypharmacy does not automatically equal addiction. Many individuals safely manage multiple medications under careful supervision. The distinction lies in vigilance, transparency, and periodic reassessment. The human brain is adaptive, powerful, and responsive to both risk and recovery. When individuals recognize that multiple prescriptions interact within shared neural pathways, they gain agency. They move from passive recipients of treatment to informed participants in their own neurological health. That shift, subtle but profound, marks the beginning of true resilience in the second half of life. At first, nothing appears alarming. The medications are taken exactly as prescribed, the refills are on schedule, and routine appointments suggest stability. Yet beneath that calm surface, the brain is performing a complex negotiation. When opioids are combined with benzodiazepines, when sedative hypnotics overlap with antidepressants, when stimulants intersect with anxiety medications, the neurological dialogue becomes layered and unpredictable. Each compound modifies neurotransmission in a specific way, but together they may amplify sedation, blunt emotional range, or heighten reward anticipation. The danger does not always arrive dramatically. Sometimes it arrives as convenience. A pill that makes sleep easier. A tablet that softens the edge of stress. A dose that restores focus after exhaustion. Slowly, the brain begins to associate relief with chemical intervention rather than internal regulation. This is where suspense quietly builds. Because the shift is subtle, it often goes unnoticed. A person may find that without the nighttime sedative, sleep feels impossible. Without the pain medication, discomfort feels intolerable. Without the stimulant, productivity collapses. The medications have not failed. They have succeeded so effectively that the nervous system has recalibrated around them. Dopamine circuits become conditioned to expect pharmacological reward. GABAergic systems reduce their natural inhibitory output because external modulation is constantly available. Stress response pathways adapt to a new baseline in which discomfort is rapidly extinguished rather than processed. Over time, resilience narrows. The threshold for distress lowers. What once would have been manageable becomes overwhelming. Polypharmacy in midlife magnifies this dynamic because multiple conditions often demand simultaneous management. A patient may see a cardiologist, a primary care physician, a psychiatrist, and a pain specialist. Each provider addresses a legitimate clinical need. However, unless there is deliberate coordination, the cumulative neurochemical burden may not be fully appreciated. Central nervous system depressants, for example, can interact in ways that increase respiratory suppression risk. Stimulants combined with certain antidepressants may intensify dopamine transmission, creating cycles of heightened energy followed by depletion. Alcohol, even in moderate amounts, can compound sedative effects and increase the risk of cognitive impairment. These interactions are not hypothetical. They are grounded in pharmacodynamics and receptor-level mechanisms. The most concerning aspect is not simply overdose risk, although that risk is real. It is the gradual construction of dependence architecture within the brain. Cross-tolerance can emerge when multiple drugs act on overlapping pathways, meaning that reducing one medication may reveal amplified withdrawal symptoms because another drug has been compensating silently. Tapering becomes more complex. The individual may feel trapped, not because they sought euphoria, but because physiological adaptation has woven the medications into daily functioning. This is the hidden vulnerability of polypharmacy. It disguises dependence as stability. There is also a psychological component. When relief is consistently externalized, confidence in intrinsic coping mechanisms may diminish. The belief that one cannot sleep, focus, or endure discomfort without medication becomes self-reinforcing. The brain's plasticity, which once allowed for adaptation to challenge, becomes channeled toward maintaining pharmacological equilibrium. That is the turning point few anticipate. It is not a crisis. It is a quiet narrowing of possibility. Yet suspense does not imply inevitability. Awareness changes trajectory. Recognizing high-risk combinations, understanding how dopamine and stress systems interact, and acknowledging the cumulative impact of central nervous system agents creates space for intervention. The story does not end in vulnerability unless vigilance disappears. When patients and clinicians engage in systematic medication reviews, when doses are reassessed, when non-pharmacologic strategies are integrated, the brain can begin to recalibrate once more. Suspense transforms into agency, and vulnerability becomes an invitation to deliberate, informed change. The most powerful shift begins when a person decides to examine their medication landscape with clarity instead of fear. Polypharmacy is not a verdict. It is a signal to pause and evaluate. Appropriate multi-drug therapy exists and is often life-saving. Hypertension may require more than one agent to achieve vascular stability. Major depressive disorder may respond best to a carefully calibrated combination. Chronic pain sometimes necessitates layered strategies. The distinction between appropriate therapy and unsafe overlap lies in intentional design. When prescriptions accumulate without periodic reconciliation, risk expands silently. When each medication is reviewed in the context of the whole nervous system, alignment becomes possible. A proactive medication safety review is not an act of defiance against physicians. It is a collaborative process rooted in neurobiological literacy. It involves asking precise questions. Which medications influence central nervous system receptors? Which alter dopamine transmission? Which potentiate GABAergic inhibition? Are any combinations known to increase tolerance or respiratory suppression risk? Is every prescription still necessary at its current dose? Could any be tapered gradually under supervision? This process requires humility and discipline, but it restores agency. Instead of reacting to symptoms alone, the individual begins to understand mechanisms. Knowledge replaces ambiguity. There is also profound motivational power in recognizing that the brain remains plastic well beyond 40. Neural circuits recalibrate in response to both pharmacologic input and behavioral intervention. Sleep architecture can improve through structured circadian habits. Dopamine tone can strengthen through exercise, goal pursuit, novelty, and meaningful social connection. Stress regulation can stabilize through mindfulness, cognitive restructuring, and controlled exposure to manageable discomfort. These interventions are not simplistic alternatives. They are biologically grounded strategies that engage endogenous neurotransmitter systems. When integrated carefully, they may allow for dose reduction or elimination of certain medications over time, always under medical guidance. The philosophy underlying this approach echoes insights articulated by addiction specialists who emphasize balance rather than excess. When reward pathways are persistently overstimulated, they compensate by dampening sensitivity. When challenge is avoided entirely, resilience weakens. Midlife offers a paradoxical opportunity. While physical vulnerability may increase, psychological wisdom often deepens. Patterns become visible. Habits reveal their long-term consequences. In this stage, it is possible to choose recalibration. It is possible to decide that health means not only symptom suppression, but functional independence and cognitive clarity. There may be moments of discomfort during this process. Adjusting medications can require patience. The nervous system may protest temporary reductions. Sleep may fluctuate. Mood may shift before stabilizing. Suspense returns briefly as the brain negotiates a new equilibrium. Yet within that suspense lies growth. Each small recalibration strengthens intrinsic regulation. Each successful taper reinforces confidence. Each intentional question asked during a physician visit builds competence. The hidden vulnerability of polypharmacy transforms into a deliberate strategy for long-term neurological integrity. This message is not anti-medication. It is pro-awareness. It is an invitation to engage with your own neurobiology as an informed participant. After 40, the body deserves thoughtful stewardship. The brain deserves protection from unnecessary chemical redundancy. Your future cognitive clarity, emotional resilience, and independence depend on choices made today with precision and courage. If you are benefiting from our topics, please subscribe, like, and turn on the bell notification so you can see our new videos early.